Thanks, Ron. I'm Richard Barron. I'm the president and CEO of the American Board of Internal Medicine and the ABIM Foundation. I spent 30 years in community practice as a primary care doctor and geriatrician before I moved to the Innovation Center where Ron now is. And I think I'd say that everybody's got to lead from where you stand. Everybody's going to have a set of opportunities to try to address this problem. There's not going to be any one issue that's going to address it. And I'm going to speak from where I stand today. We're here because it's the anniversary, it's actually 12 years, not 10, since the release of the IOM report on cancer survivorship, which put it on the map, and people are really concerned about looking back. That, of course, transformed the field, created different expectations for how people should think about it. I checked our records today. There are 13,251 oncologists board certified by the American Board of Internal Medicine. 78,200 of them, that's 59%, trained before the report was issued. 41% have certified since the report was issued. It's always attractive to sort of make the move to training. Let's improve education. Let's be sure everybody does things better. But the bulk of the clinician workforce at any given time are people who are actually out there in practice. Why does that matter? Because things really change. ePatient Dave asked, what can we do to make sure that doctors are forced not to be out of date? What do we do with doctors who say, I just want to have my individual opinion? Well, with knowledge changing and changing based on literature and based on evidence, we need to think about ways that, that doctors stay current. Why does it matter? Well, let's look at breast cancer survivorship. Many of you have heard of the Choosing Wisely campaign from the ABIM Foundation. Here's two recommendations from ASCO relevant to breast cancer survivorship, which are different than 5 years ago. Don't perform surveillance testing or imaging PET-CT for asymptomatic individuals who've been treated for breast cancer with curative intent. Another one, avoid using PET or PET-CT scanning as part of routine follow-up care to monitor a patient for cancer recurrence in asymptomatic patients. So I come to this panel, in addition to my professional role, almost a year to the day after my wife completed successful treatment for breast cancer. Last week, we ran into a physician colleague, friend, and his wife in the grocery store. And the wife said, gosh, you look terrific, to my wife, which she does. And then said, how often are you getting your PET scans? It's a sort of basic, oncofertility is now a quality measure in ASCO's COPI program. It did not used to be. So as Ron said, this is about solutions, not identifying problems. How do we make it more likely that doctors are staying current, that doctors are keeping up, that doctors are practicing today's medicine? I think that we need to be thinking about ways that that we move from lifetime certification, where doctors get certified once in their career forever, and are expected continually to demonstrate ongoing knowledge and expectation. To say, trust me, I read journals, I go to CME, that's probably not an adequate approach. How many of you have heard of the Dunning-Kruger Effect? Anybody? It basically, it's been studied in a variety of settings that people are not good at assessing their own knowledge, and the people who are worst at assessing their own knowledge are the people who have the least knowledge. But the less you know, the more confident you are that you know what you need to know to do what you do. And that's actually, it's been demonstrated in a variety of settings. And we can't just have a regime where we have people out there practicing over the course of their career saying, I know what I need to do. We give an assessment, an exam. It's been subject of a lot of criticism. It's a blueprint that designs an exam. We recently went to all the board certified oncologists in the country and said, what do you think's important on this blueprint? I will tell you that cancer survivorship changed a little bit. The content of it changed. It moved before blueprint review. It included fertility, secondary primary cancer, secondary cancer prevention. Afterward, it added, in addition to those three, non-malignant sequelae and surveillance. But it's still less than 2% of the total blueprint is going to be on this. And that's because we have a lot of expectations for oncologists. We expect that they'll know current management. We expect that they'll know current diagnosis. We expect that they'll know a lot of things about how to be an oncologist. So we now are working very closely with ASCO, you all know who ASCO is, to try to craft what should the assessment be. We are committed to the idea that there should be an assessment, that people should not be guaranteed the credential for life, that part of a solution to a rapidly evolving field is having a flexible credential. Patients depend on their doctors to be practicing today's medicine, and some ongoing assessment needs to be part of that. Some of you may know, some of you may not, given the controversy over the maintenance of certification program. There's now legislation pending in 25 states, advanced by state medical societies, to make it illegal for hospitals or medical groups to use the certification or maintenance of certification credential as part of hiring, credentialing, privileging, or payment. It's part of a broad backlash of accountability, and frankly, I think we need to ask ourselves whether that's the right direction we should be going in as a country, or whether we need to be thinking about this as a solution. So Ron said policy solutions. My proposed policy solution: maintain an oversight regime of professional self-regulation to help oncologists stay current in their field and to represent to their patients and their colleagues that they have done so. Thanks for inviting me.